Hello, my name is Melany Atkins, and I'm the Director of Cardiac Imaging at Fairfax Radiological Consultants. I'm also the Medical Director of the Fairfax MRI Center, and today I'm going to be talking to you about integration of deep learning into routine MR examinations. Today we're going to discuss air coil technology and the AirTouch software that's integrated into the air coil. We're going to then change directions and discuss artificial intelligence integration, including the RX technology as well as deep learning image reconstruction. Air coil technology has really been a game changer in the development of coil technology. I think many of you are familiar with the air coil. As you can see here, our patients say that it's like wearing a blanket. It's excellent technology for both the patient, as it's very comfortable, it's very easy to use for the technologist, and it also affords excellent image quality. As you can see here on the right, we have examples of the newer MP coils. They can be used for extremities, as you can see here on the left, excellent for shoulders, knees. They've been optimized for cardiac imaging. Now, air technology is excellent for a number of reasons. It has a much more flexible design. It's lightweight, like I mentioned previously. It's really like just wearing a blanket. It conforms to the body. It undergoes rigorous testing with the coil elements, so it's very reliable, and it has reduced power consumption. In addition, it's got very high SNR. You can see here on the right, on the top we have axial lava images, and coronal reconstructed images from an EOVIS study in a patient with multiple hepatic metastases. Now, one of the biggest limitations of coil technology is really overlap versus underlap. And what you can see here in this video demonstration with traditional coil technology, as we move the coil elements too close, we get decoupling. But if you have the coil elements too far away, then we get regions of signal loss. And the critical overlap or the issues with decoupling are really no longer a problem with coil technology. We don't have the shadowing or signal loss like we do in traditional coils, as you can see in this graph here on the right. And this is an example of the diaper coil. With traditional coil technology, you would never be able to overlap all of these coil elements in this manner. And the diaper coil is in development for utilization for prostate imaging and other pelvic imaging to get really high resolution images of these small field of view items in the pelvis. This is just an example of all of the coil elements that are going to be overlapping. And again, this would never be possible with traditional coils. So the software that's integrated in the air coil is the AirTouch software, which really enables improved workflow efficiency. It's very easy for the technologist with single touch landmarking with a simplified technologist workflow. And so this allows for ease of the technologist, but it also allows for improved patient throughput. The AirTouch technology also has intelligent coil location and coil element selection to really optimize image quality for the body part that you're planning to image. And here's an example of that, really single touch landmarking. There's no complex coil modes that you have to choose. It's really just a single click coil selection. And the user interface really requires limited user input. In addition, the auto coil element selection also optimizes choices as well for things. For example, here we have our parallel imaging. The calibrations for parallel imaging options are automatically integrated into the pre-scan. And if patient coil element combinations were to change throughout the exam, this would be automatically integrated. So here's an example of a two-station whole body scan for a patient with lung cancer. You can see on the right we have the rotating radial MIPS from the coronal DWI. We utilize two air coils for this image acquisition. And then you can also see the T2 weighted sequences and the coronal pre in the middle. And on the video on the left, you can appreciate how nice and easily mobile and light this air coil is. Air coils are excellent really for multi-modality imaging in the world of body imaging. On the top left, we have an axial T2 from a prostate acquisition. You can see on the bottom left, we have a large rectal mass with this coronal T2 acquisition. And then we have our lava flex images on the right, again, a hypervascular liver lesion, and as well as a bladder cancer on the top right. We utilize the air coil for all of our cardiac images. You can see here we have short axis images in a patient with hypertrophic cardiomyopathy. We've got horizontal long axis images on the right. And in the middle, we have 4D flow images you can see in this patient with mitral regurgitation. All of these, of course, were utilizing the air coil. Musculoskeletal imaging is really nice with the air coil. Beauty here, bilateral hips, no coil intervention needed. You can see this was an arthrogram. Here we have a labral tear with coil or with contrast extravasation. Vascular imaging, you can use multiple air coils if you need to do whole body or runoff imaging. Here we've got tricks of an extremity here on the right where we wrap the air coil around the hand. We've got abdominal imaging or abdominal MRA on the left, and we have MIP images from a chest and abdominal MRA in the middle. So we're going to change gears a little bit now and look at other areas of artificial intelligence in MR imaging. So I did want to talk a little bit about the basics of artificial intelligence so we can better understand some of the utilization in the coming slides. Traditional techniques versus deep learning. When we talk about traditional techniques, we're really talking about image processing, which is not trained on data, and using more basic region filling, automatic brightness, contrast, etc. Once we move to to traditional deep learning, these are more handcrafted features like logistic regression and decision trees. And then the final step, once we've moved to deep learning, is really when we're training on raw unstructured data. And we're utilizing convolutional neural networks for image classification. And these neural networks we can apply additional data into the system and increase the complexity of the deep learning. And so when we talk about AI versus machine learning versus deep learning, I think this is a nice explanation to try to grasp the concept of these, where artificial intelligence is really the overall umbrella. It's the broadest area encompassing any machine that can think and learn. Whereas machine learning is a smaller subset of AI, where the user is actually telling the machine the correct answer, and then the machine learns on its own. And deep learning is really our highest and most advanced subset of machine learning, where the machine is acting more like a brain and learns to recognize many layers on its own after training on these very large data sets. And so I like to use the analogy of the AI in the automotive industry, where the automotive industry would be the overall umbrella, or the AI, and the machine learning would be an example of that would be the advanced driver assistance system, which recognizes the speed limit sign as you're driving down the hallway or driving down the highway, and it also knows what speed you're driving and alerts you that you're speeding, whereas the deep learning would really be the self-driving car. And the self-driving car is really a more recent deep learning success. You can see here that the system is recognizing, for example, the pedestrian and the lane marking detection here, utilizing natural language processing. Another recent deep learning success is something like speech transcription with Siri or Google Voice, where she learns as time goes on. So with image recognition with deep learning, we're learning from large amounts of training data. And so we're creating representations at multiple scales with large amounts of data. And so we're really shifting from optimizing small features to optimizing the entire model. And so you can see here on the left, kind of an example, you're inputting a large amount of raw data, and as the machine gets more complex, it moves from low-level features to mid-level features to these much higher-level features. So AirX is intelligent slice prescription utilizing deep learning algorithms to identify anatomical landmarks and automatically set up slice prescription for many of our imaging modalities. So it's currently available in the brain. You can see here we utilized a large amount of training data into the anatomy engine, which then went on to localize key features within the brain. And then additional deep learning algorithms were placed, and then we have the ability to prescribe the same scan plane each and every time. And so in development are AREX for abdominal imaging, spine imaging, and one that I think is really important is cardiac imaging. Around the world, we really have a limited number of technologists who are trained to be able to acquire cardiac images. So if we had some automated slice prescription, it would really help some of our less trained or more rural areas to have access to these high-level cardiac MR images. In addition, in the abdomen or in the brain, when we're frequently scanning patients with metastatic disease, to be able to scan the exact same imaging plane every single time is a real advantage. So I'm going to move on to talk a little bit more about cardiac imaging and automating image acquisition. So this is compliments of Dr. Albert Schau at UCSD. And so they utilize convolutional neural networks to localize major anatomic landmarks. For instance, here you can see below, the AI algorithm has localized the liver and the spleen, the kidney, and the right kidney. And so they did a large project in order to localize the major cardiac prescriptions. And you can see here for the long axis stack, they utilized a long axis localization model to find both the cardiac apex and the mitral valve, utilizing a UNet-based heat map regression to find these cardiac landmarks. And then they compared the deep learning predictions to the ground truth. And as you can see here, there's excellent cross-validation. They did a similar process for localization performance for the short axis stack. The original model that they utilized here, they started with mitral valve slice localization utilizing a model to identify the mitral valve. They then placed a bounding box around the heart to decrease the search space for the anatomic landmarks. And then they put a third localization model for a final localization network for fine-grain anatomic localization. And again, you can see here they have excellent cross-validation. This is this is comparison looking at the AI algorithm in red to the radiologist drawing of the slice prescription versus the technologist, and you can see there's really excellent uniformity between all three. And this is an example of AI-driven image acquisition on their scanner at UCSD, having the scanner use the AI algorithm to scan the heart and obtain the major cardiac slices, slices. So I want to change directions now. We're going to discuss deep learning image reconstruction. So I think everyone is familiar with standard MR image reconstruction, utilizing conventional K-space, and we have a Fourier domain. We're utilizing multiple raw data filters to get rid of the areas and truncate the areas where we have a low amount of information. Utilizing Fourier transform, and then multiple image filters are applied to decrease areas of low SNR. And so we end up with this final standard reconstructed image that you can see here. And blown up, even with the image filters, we end up losing spatial resolution, and things like Gibbs artifact remain. So we really need a better algorithm to get rid of some of these residual artifacts and areas of noise. So we can apply deep learning-based MR image reconstruction, and we don't have to use any of the raw data filters or image filter. And the deep learning reconstruction is really an integral part of the reconstruction from the beginning. And so it's high resolution. We don't have to worry about any of the truncation artifact, and there's significant noise reduction. And so as we see this blown up image versus the standard recon image, we don't have Gibbs artifact. We have high resolution and really imperceptible noise. And so for the remainder, I would like to go over a few examples and cases of how we utilize deep learning reconstruction and how we plan to use it in the future as well. So you can utilize deep learning reconstruction to increase your resolution. So in this example of a patient, we're looking at blow-up images of the pancreas. With conventional reconstruction, you can see that once we end up with super high resolution, we have a significant amount of noise. Whereas with deep learning reconstruction, we can obtain this super high resolution, and all of that noise, we don't see that noise at all. We can see excellent resolution of the pancreatic lobulation here. But you can also, if you don't want to use deep learning reconstruction for resolution, you can combine that with productivity as well. And you can see here in this T2 weighted sequences of the prostate, we have on the bottom left here, we have a 4-minute 52-second acquisition for our traditional T2 weighted sequence. In the middle, we have a much lower resolution half-nex acquisition, same slice thickness. That was 1 minute 30 seconds. And then you can see these are the same raw data. When we utilize DL Recon, we can see that the noise is significantly reduced. And I would say that this image on the far right is equal to or arguably improved from the conventional reconstruction, which took almost 5 minutes. This is another example of a gentleman with BPH. You can see here that when we have these high-nex long acquisition time images, we often get blurring secondary to either organ motion or it could be rectal motion causing some of this organ blurring. When we do the faster low-nex acquisition, we don't have problems with blurring, as you can see here, but we suffer from low SNR. And finally, when we reconstruct the low-nex images with DL Recon, we have the best of both worlds. We don't have organ blur and we have excellent SNR. This is another example of utilization in the abdomen when we're doing conventional versus DL Recon. I think that you can appreciate here, there's really is a significant decrease in SNR on the DL Recon image. The visualization of the liver here is quite improved with DL Recon. This is another example. This is a patient with prostate MR where we utilized the endorectal coil. And as you can see here, we have artifact from the endorectal coil on the conventional reconstructed images. These are reconstructed utilizing both the surface coil and the endorectal coil. On the right, when we utilize only the surface coil, which in theory should be significantly less SNR, we don't have the artifact from the endorectal coil, and we have excellent resolution. This is an example of a patient we did recently at our facility. Here's our traditional T2 high resolution axial oblique images, which were 4 minutes 12 seconds to acquire. This is with glucagon utilization, and I think you can appreciate here that we have some organ blurring, or we have some blurring of the muscularis and the mesorectal fat here. This is our low resolution image where we decrease the nex and also increase acceleration, and we have an acquisition time of 1 minute 16 seconds. When we reconstruct with the DL Recon or the Air Recon algorithm, I think that you can appreciate the tumor extension into the mesorectal fat much better, and you can also appreciate the muscularis. And then we don't have the blurring motion that we have in the long acquisition examination or long acquisition series. So this is an additional example of a rectal cancer patient, and I think you can appreciate similar findings that we have here. Again, it's hard to see the outline because of some of the blurring that we have. With the low nex 1 minute 16 second acquisition, I think we can appreciate here we have a lot of noise because of the low resolution. But once we reconstruct with the deep learning algorithm, I think that we can much better appreciate the tumor border as well as the muscularis and the mesorectal fat. Moving on, this is an example of a cervical cancer. This is a large cervical cancer that's extending into the upper vagina. And you can see here with our long acquisition, 2 minutes 47 seconds, I certainly think that you can appreciate the tumor and the extension, the parametrial extension, and the tumor borders. But with the quick acquisition with 1x and increased acceleration of 58 seconds, when we run that through the deep learning algorithm, I think the borders are much better appreciated with the decreased noise and decreased motion blurring. This is the same patient, the coronal images that we acquired. And again, I think you can appreciate similar findings, 2.5 minutes. This is the low resolution 58-second acquisition. And then once we put this through the DL Recon, I think you can appreciate, again, the borders of the tumor and surrounding structures with significantly decreased noise. So thank you very much. Today we've discussed air coil utilization as well as artificial intelligence integration in routine MR examinations.